I want to thank AROC for inviting me. I've been coming to these lectures since I was a student. This is the first time I actually get to speak, so this will be pretty fun. These are subjects I'm excited about. I get the after the lunch, trying to make you excited about vaginas. So hopefully I threw some pictures in here, at least keep you entertained while you're sitting here. But just also another really quick story is I didn't go to medical school to look at vaginas all day long. I don't know how I ended up here, but one of my favorite stories is I have a good friend who's a podiatrist, and not too long ago I said to her, "God, how do you look at nasty feet all day long?" And she looked at me with a straight face and she said, "Are you serious?" And I'm like, you know what? You don't know. You get desensitized. You don't realize what you're doing. All right. So, pelvic pain. Just disclosures, I am a speaker for Allergan on Botox, and I am a co-inventor of a pelvic physical therapy device. Our goals are just to basically understand the pathophysiology of chronic pain, the differential diagnosis of pelvic pain, and overview of treatment options. So, pelvic pain is vaginal pain? Not quite. Pelvic pain is a chronic pain condition. So just like any chronic pain conditions, it's the same exact thing. You have to look at it like that. So with patients with pelvic pain, I know everyone automatically thinks of the gynecologist, but really it's a multifactorial condition. So we're going to talk more about the pathophysiology of pain, and a little bit later, a little bit about actual pelvic pain. So the physiology of pain is really meant to protect us from some sort of noxious stimuli. So it's like putting your hand on that hot burner, and the idea is you're supposed to feel that and pull away. But with chronic pain, you start having repetitive pain. You have changes that actually occur in the neurotransmitters and the chemicals at the site itself. From my standpoint, I see a lot of mast cells in this tissue. But then also you have the Hebbian theory of pain, where, to summarize it, is cells that fire together wire together. So in looking ahead, you should have your cells that receive touch, the ones that receive mechanical pain, and the ones that receive noxious stimuli like heat. So with chronic pain, if you get repetitive firing of those cells, the other pathways near it are going to start growing together, and so you can get a confusion of the cells. So now you no longer feel chronic pain, but with you no longer feel like light touch, but the body will start to interpret that as pain. So the other thing that happens with chronic pain is that if you have a noxious stimulus that doesn't go away, like putting your hand on that stove and then pulling away, if you have the chronic noxious stimuli, you're going to start building up more receptors. So initially you'll have more receptors in the periphery, then it starts to centralize. Then you start getting it in the arm. Say if it's your arm, you start getting the arm, and then you get an upregulation of receptors in the brain. So once you have centralization of pain, like I tell my patients all the time, when it comes to their pelvis, I could theoretically cut off everything from their waist down. They're still going to have vaginal pain because they still have those receptors in their brain that are wired to that area. And it goes along with any kind of other pain conditions. If somebody has, phantom, the amputation, they're still going to feel their toes because they still have those receptors in their brain assigned to that region of the body. The other thing that happens with pain is that you have an activation of your glial cells. So you'll actually get an increase in growth of these cells. And increased growth of glial cells in themselves can lead to other conditions. It can cause symptoms of fatigue, depression, actually activate the pituitary system. So you're also going to get other medical conditions that are going to develop outside of the pain itself. So how I like to explain my patients is if I walked up to you with a hammer, you'd pull away. And if that was it, you'd be fine. But if I walked around every single day hitting you on the hand with a hammer for 3 months, on average I think it's about 3 months for chronic pain to develop, sometimes less, sometimes more, but you would start developing increased receptors in your arm, now increased receptors in your brain. So now 3 months down the road, I take a big feather and I touch your hand, your brain's going to perceive pain. So not only are we dealing with the receptors in the periphery, but we're also dealing with receptors in the brain and also how your brain perceives that pain. So looking at pain from a perception standpoint is our brains are receiving constant stimuli throughout the day, just like walking down a busy street, constant stimulation. So if you're a person that has an eating disorder, your brain is going to pick out all the food areas of that street, and you're going to see those things. If you're an alcoholic, you're going to see all the bars and all the alcohol advertisements on that busy street. Or say you have sex addiction, you're going to pick out all the images of whatever you're attracted to. So pain is the same way. Somebody who develops chronic pain, their brains are going to become hardwired to pick out painful stimuli. So things that make people kind of susceptible to developing chronic pain, some of it's genetics. Some of it is how you perceive things, like catastrophization, and how you deal with the stress of pain. Also, there's going to be some chemical and structural differences in those people. So what happens in chronic pain? Your major symptoms can be the pain itself. A lot of times they develop insomnia, depression, and fatigue. Also, you'll get an increase in the hypothalamic pituitary adrenal axis. So with that, you're going to see high levels of cortisol, which can then, and also effects of sleep and reproduction and growth and immunosuppression. And then the secondary symptoms of pain are going to develop into anxiety around the pain and around activities that cause them dysfunction. A lot of times they'll start affecting their eating habits, the feeling of hopelessness, and then the allodynia, where light touch and non-noxious stimuli will now be perceived as pain. And then that affects behavior. So now patients will start to avoid things that cause them pain, but then that causes them depression, so then that causes more pain, so it becomes this interlinked system. Now, the other things in chronic pain is you'll see an increase in the sympathetic nervous system. So they can also develop other conditions like hypertension, tachycardia. And then what you'll also see in pain patients is they will get a reflex muscle spasm. So the muscle spasm is trying to protect their body. So their body realizes that they're in pain, and now it's trying to splint against that pain. But that splinting itself now causes a decreased blood flow to the tissue that then causes a noxious stimuli, which causes more pain. And then from a gynecologic standpoint with pelvic pain, these issues can affect how they perceive sex. So that if a patient has pelvic pain and now sex aggravates it, they're going to reflexively tighten up before intercourse, which is going to make intercourse more painful, which is going to make them spasm more in their pelvis and then avoid intimacy and further encounters. So what actually causes chronic pelvic pain? There are so many different things that can cause pain in a person, so there's so many different reasons that can cause chronic pelvic pain. It could be neurologic, it could be infectious, inflammatory, chemicals, dietary, and a lot of times we just don't know. So what kind of things do those patients present with? They may come complaining of pelvic pain. That's an easy one. Also vulvodynia. But sometimes patients have what we consider like a pelvic pain condition, but they don't always present complaining of pain. They may have urinary symptoms. They may have urgency, frequency, recurrent urinary tract infections, constipation, bowel symptoms. And then a lot of the pain conditions have their brother and sister associations with, they may have more than one inflammatory condition. They may have interstitial cystitis, fibromyalgia, irritable bowel, because these are all chronic pain conditions. So they're usually not by themselves. And then there may not be anything triggering the pelvic pain from the genital organs itself. It could be something gastrointestinal. They could have neurologic conditions, herniated discs, orthopedic issues, allergies, and dermatologic conditions. So going on the gastrointestinal theories behind chronic pain and inflammation, from the pain field itself, there's a lot going on now with leaky gut. So the idea that the lining of the intestines is your immune system, and now those tight junctions in the intestines get affected from stress, from diet, from antibiotics, and now irritants can leak through the intestines, bacteria, viruses, food irritants, and that can be interpreted by the body inflammation. And people present their inflammation in different ways. Some people will have pelvic pain. Some people will get migraines. I have a good portion of patients in my practice, especially interstitial cystitis patients. This theory of leaky gut has always been out there. Now that a lot of the literature is starting to get more into this, finding that them just changing their diet and even going towards the FODMAP diets, which are the foods that are high in certain sugars, that their bladders start to feel better. They might not have had any kind of gastrointestinal symptoms, but now their pelvic pain gets better. Other things, when working up these patients, sometimes I find Tarlov cysts. So Tarlov cysts are these meningeal cysts that are present, and a lot of times I find them in the sacrum. The problem is trying to find neurosurgeons that are willing to deal with this or believe in it. And I'm not trying to insult any neurosurgeons. It's just very difficult. They're actually a Tarlov Cyst Foundation that only lists about 3 doctors in the country that will actually address these cysts. But I've had some patients who've gone down to Maryland, had these cysts drained or removed, and their pelvic pain symptoms get better. I think one of the biggest problems is that this is not a great area to be doing surgery on. Labral tears. This was something that I wasn't really aware of when it came to pelvic pain. My pelvic physical therapists, which are invaluable, brought this up to me once, because sometimes I'd have these patients with pelvic pain. I'm looking everywhere. I'm doing all these tests. I can't find anything, and they were testing the hips, and then we're getting MRIs and finding labral tears, and then those labral tears were getting addressed, and their pelvic pain got better. So my theory is with the labral tears is that even if they don't have hip pain, that their body's sensing some sort of disorder, and then the pelvic muscles are tightening to splint against that hip pain, and now they're having that pelvic disorder. Piriformis syndrome, just another thing in the pelvic area that can refer pain actually into vagina, bladder, pelvis. Coccyx disorders, another thing that my pelvic physical therapists have enlightened me to. Doing what's called a dynamic x-ray of the coccyx. They do one when they're sitting and then we're standing, and then seeing the movement of the coccyx. That can not only put pressure on the rectum, which can refer pain into the pelvis, but it can also put a lot of strain on the sacrospinous ligaments and then affect and cause pudendal neuralgia. I was in the OMT lecture earlier, and I was talking to Dr. Ang, and I asked him if anybody had any information on adjusting a coccyx. I got brave, and I did one in my office recently. Terrified out of my mind to do it because I don't usually do OMT, and let alone on a coccyx. But the patient, for at least a day, it was the first time in 4 years she had gotten relief of her pain. So I'm going to end up revisiting that with her. And then your neuralgias. So just like you can develop carpal tunnel in the wrist, you can develop entrapment syndromes of nerves in the pelvis. And knowing where those nerves innervate and looking at the patterns, you can sometimes diagnose an entrapment syndrome. And then in general, going back to the glial cell inflammation, sometimes the medicines and the treatments that we use for pain can actually worsen pain. A lot of studies coming out now showing that narcotics actually increase glial cell inflammation and actually contribute to pain itself. So, talking about the treatment for pelvic pain, a lot of times these patients will present with pelvic floor muscle spasms. So what I try to educate the patients on is if your leg was spasmed, heat, stretch, massage. Vagina, pelvis, you got to get a lot more creative with that. soaking in a hot tub, sitting in a hot water bottle, stretching, sometimes using a dilator or vibrator and using it as a handle to stretch towards the rectum. Fiber products to manage the constipation that can occur with this, and then addressing their sexual issues. Pelvic physical therapists. In New Jersey, we're pretty lucky. If you look around, there's a good number of them, and increasing in numbers. But they're definitely invaluable. I can't talk enough about them because I don't have the time to do all this, and they are just wonderful with dealing with manually going in there and relaxing the muscles, or even helping to diagnose hip disorders or even lower thoracic disorders will refer pain into the pelvis. In pelvic pain, with any pain condition, exercise. Now this is very difficult to get people in pain to exercise, but exercise producing dopamines can help relieve the symptoms of pain. What I try to tell my patients is find a body part that doesn't bother you. Hopefully, it's upper body, and try exercising that body part, just any kind of movement. Start with 5 minutes a day, and then just keep adding, like 2-3 times a week, and then every week add more time, more frequency, and you can actually help with the way you perceive pain and your how they react to pain and inflammation. I find now that using technology, the smartphone apps, are one of my best tools because it's very difficult to get these patients to go someplace. They're tired of going to doctors. So just doing a bladder tracker or a diet tracker, that's working with mindfulness. Sometimes if they're aware of what they're eating and what's causing them symptoms, that in itself can help. There's pain diaries. A lot of relaxation apps, hypnotherapy apps, mindfulness, cognitive behavioral therapy. There's a whole bunch of them out there now. And there have been some studies using virtual reality in treatment of pain, which is fascinating with these functional MRIs where no longer we say like, okay, meditation is great for you for pain. It sounds good, but how do you prove it? Now with these functional MRIs, I have a couple studies here that show patients in chronic pain that were put through this study where they didn't have virtual reality, and then ones that were exposed to wearing these little goggles, watching some video with penguins on it, got their mind distracted and actually showed changes in their brain that corresponded to improvement in the sensation of pain. Hypnosis. They were able to do some other functional MRI studies where they took patients with pain, then they were able to hypnotically induce pain and show changes in the brain, and then they were also able to reverse that and hypnotically reverse pain and saw changes in the actual structure of the brain. Acupuncture, we have studies showing how that affects how the brain perceives pain. Meditation. The nice thing about these, like meditation and psychotherapy and psychiatric support, I unfortunately had a patient recently who I'm trying to get her to see a psychiatrist or a psychologist or somebody in the mental health field. The moment I brought that up, she thought I was calling her crazy and ran out. I got her back. She actually did come back, thank God, and I'm trying to explain to her, no, look, I have studies that show there are brain changes that happen in chronic pain, and we can reverse those with these other therapies. There was a study that came out not too long ago with patients in chronic pain, and they did functional MRI, showed which parts of their brain lit up, and the only therapy they did with them is put them in an eight-week course of cognitive behavioral therapy. After 8 weeks, their pain scores by questionnaires went down, and on functional MRI, their brain structure improved. Osteopathic manipulation. So if any of you were in the OMT sessions earlier today, we dealt a lot with the pelvic floor and pelvic OMT. And then I do have a couple busy slides in here that are probably more just for your education purposes if you want to go look back at them, but these are how all the different types of modalities influence pain's transmission, pain perception. So medications, I don't like to have people on long-term medications if I can, but with pain patients sometimes it's difficult. I personally try to stay away from the opiates, or if they're on if they come on opiates, try to get them off as soon as possible. But go more towards the tricyclics and the muscle relaxers and the Neurotins and Lyricas. Also another busy slide just talking about how those things influence pain transmission. You can go back and take a look at that if you want to. But antihistamines. Also, looking at pain can often be viewed too as like a chronic regional pain syndrome or reflex sympathetic dystrophy. So in pelvic pain patients, you get a lot of hyperemia of the tissue. Biopsies of that tissue will show high level of mast cells. And so going to treatments like antihistamines or mast cell stabilizers can actually help. Especially in the use of interstitial cystitis, there are some medications on the market that have, like Elmeron, or that are indicated for interstitial cystitis. But I'm finding less insurance companies are covering it, especially Medicare will not cover it at all. And there's side effects. But putting patients on antihistamines or your montelukast, your mast cell stabilizers, they tend to do very well with those. Medications, they're used for erectile dysfunction. So, and I know I'm supposed to use the generic names, but I can't remember all the generic names, but your sildenafil, your Viagra, supplements of L-arginine. There was actually a study that just came out using daily Cialis would increase blood, you're using it for increased blood flow. So the increased blood flow to tissue, relaxation, and help with pain. I have some patients who use these medicines just during intercourse to try to get the muscles to relax and decrease their pain with intercourse. Topical preparations, your compounded preparations, there are a lot of studies coming out with that. I use a lot of compounded preparations in my office. I put the little star there because some of these things, it's hard to find evidence-based medicine to prove that these things are good, but vaginal Valium we use a lot of that in my practice and in the pelvic pain community. There was a study that came out probably a few years ago where you don't actually have to have it compounded into a cream or suppository. Just taking a 5 to 10 milligram tablet, wetting it, have them put it in the vagina, it was just as beneficial as using a suppository. So because of how inexpensive that is, that's usually my go-to. I usually start with that one. And trigger point injections. 72% of patients will report an improvement with trigger point injections. So trigger point injections, basically finding the tender spot in the muscle, and really from an osteopathic standpoint, you could probably do the same thing with just pressure points, just pushing on that muscle. But when it comes to trigger points, you can inject. So there's two different ways of injecting. You can do wet injection or dry. So dry is just putting the needle itself into the tissue, and you can have improvement in just that alone. I'll tell you personally, I just have a problem. Sometimes it's hard enough to talk somebody into sticking a needle in their vagina and then be like, oh, I'm going to stick a needle and not do anything else. So a lot of times I will use lidocaine, Marcaine. Steroids have not proven to be beneficial, but I still do steroids. And then there's a bunch of studies coming out on Trameal, which is a homeopathic injectable. It's supposed to affect the cascade of inflammation a little higher up than the NSAIDs. Nerve blocks, this is where I get my pain management people, my interventional radiologists in to do any kind of guided blocks. In the office, I will do pudendal nerve blocks by feel, but there's a bunch of different areas where you can affect the nerves. Interesting enough, in patients I've had C-sections, hysterectomy, laparoscopic surgery, it's not unusual for them to get ilioinguinal pain that refers into the pelvis. And you can even just palpate their abdomen and find that area and find the area of maximal tenderness and inject that area. And then Botox. Botox, getting it covered for pelvic pain is a little bit difficult, but there's tons of things on the horizon with the use of Botox. But Botox helps pain in two different ways. It affects the SNAP25 receptors, and by doing that, it not only decreases muscle spasm, but will actually affect the nerves themselves on how they transmit the pain signals. So it can be used actually in the muscles themselves, or in the case of like vulvodynia, you can inject it in the tissue. And then neuromodulation, using some sort of electrical energy to confuse the nerves. Goes back to the gate theory of pain, where if you overstimulate a nerve with another kind of stimulus, then maybe it'll block out that pain perception. So using TENS units. This picture is actually interesting. It was from a study done in England on women in labor, and they were able not to do epidurals, but just help their pain through labor just with the use of a TENS unit on the lower back. I recommend 30 to 60 minutes a day, but theoretically they could wear it all the time. Percutaneous tibial nerve stimulation. This is a modality that's actually used for treatment of urgency and frequency, and that's what it's approved for. So it's not approved for use in pelvic pain, but there's tons of studies that show it can actually decrease pelvic pain. The idea is we stick an acupuncture needle in your percutaneous tibial nerve in your ankle and electrically stimulate that nerve, 30 minutes once a week for 12 weeks. And your sacral neuromodulation, or your interstims, that's actually placing a little stimulator wire in the low back through the S3 foramina to also, it's indicated for urgency, frequency, fecal incontinence, urinary retention, but has shown improvement actually in constipation and in pelvic pain. But the insurance companies will not pay for that as of yet. And then there's your spinal cord stimulators. And lastly, and I try to use this lastly, is actually nerve release procedures. Because of, say, with pudendal nerve release, you will get entrapment you can see entrapment on these patients of the nerve and scar tissue. The pathology of why that happens, not really clear. These surgeries are tough because by the time someone gets these surgeries, they've been usually in pain for a very long period of time, and the surgeries are not often very successful. And even if it is physically and anatomically successful, it can take up to 2 years for the nerves to recover. And then it's very difficult when you're doing surgery not to cause additional scar tissue. So I try to really take care of these conditions with other modalities first. So the biggest thing with chronic pelvic pain, and I try to instill in my patients, that this is a team approach. That many times by the time they get to me, they're like, okay, I'm done, fix it. Well, I can't fix it on my own. I really need everybody else involved. I need the psychiatrist, the psychologist. I need the gastroenterologist, the neurologist, the orthopedics, dermatologist. I mean, pretty much every, I'm trying to think if there's a, area of medicine that's not involved in this. But you really need to have a team approach and multiple layers of doctors involved in the care for this. And just like with any pain condition. All right, so the key is that pelvic pain is a chronic pain condition. It needs a multidisciplinary approach. You have to address the sexual issues and then also manage their expectations. A lot of times it's taken them a long time to get to this point. It's going to take a long time to reverse it.